All right, while people are logging in, I want to say good morning to everybody. I'm the chair of the Chamber of Commerce Health Council. Today is a joint meeting with the council as well as members of the Northwest Cares Group. Want to welcome everybody. We have a wonderful speaker today, Dr. Mark Hirko from Sharon Hospital and Putnam Hospital. I think what we'd like to do is, like last time, we're going to let our guests present and speak, and then if there's time left at the end, we'll allow for folks to give an update of what's going on in your organization. So, Lance, what do you think here? We've got a pretty good crowd here. You want to get started?
So we have 24 participants. I did turn off the chime, so if people join, we won't be disturbed. So if you want to go ahead and get started, you can.
Okay, so I guess, Marita, would you like to do the introductions here today for the new Vance group?
Surely. So good morning, everyone. Thanks for joining us. So our speaker today is Dr. Mark Hirko. He is the president of Sharon Hospital, and we appreciate the opportunity to speak. We wanted to give an update to the group on our transformation plans and a general operations update at the hospital and across New Vance Health. And with that, we will have a Q&A at the conclusion of the presentation. So feel free to send in your questions in the chat throughout and at the end. And with that, I will pass it over to Dr. Hirko.
Thank you, Marina. And I'm hoping that I can have my part done in less than 30 minutes, maybe even less than that, so we can leave plenty of time for questions and answers. So let's get going. Thank you. So what I wanted to kind of go over today was to give you updates, particularly with COVID, updates about our transformation plan, what we've initiated in regards to the plan, how our progress is based upon issues and considerations with the state, and then go over any questions or any issues that anyone would have regarding our topic today. So next slide, please. So why don't we start with COVID? We got hit hard during this latest surge. At one point, greater than 70% of all patients at Sharon Hospital were COVID positive. And we, in addition, with the issue with the great resignation that has occurred over the past year, we, as a health system, out of 12,500 employees, have greater than 2,000 job openings at present. And add to that 900 employees that actually had COVID and were out at the same time. We had close to a third, 25 to 35% of all our employees were out during the surge, where we maxed out at over 34% of all hospital beds in our system were COVID positive. So I really want to thank the community, EMS, all of our partners at our various extended care facilities, our rehab facilities, and even everyone here for helping us kind of get over this surge. Currently today, I'm proud to report we have one person that's COVID positive only at Sharon, and we are encouraged by the positivity rate, which has dropped down to around 3 to 4%. At one point, we were running close to 34% positive testing rates. Good news, since the rate has dropped and the incidence has dropped, as of yesterday, we've gone back to open visitation of the facility, both in the emergency room and inpatient beds. Now, it's still not completely unrestricted in that you have to show proof that you are COVID negative and have no active symptoms to come in as a guest. We had issues over the previous 4 months where we've had to restrict at one point only guests for life-threatening issues or children. We were allowed one allowing one guest at that point. But at present, we are allowing open visitation, with the only restriction being you must be COVID negative and show proof of that. As an update to vaccines and boosters, again, data has been proven hands down that sure, people did become infected with COVID despite having a vaccine or booster, but the data also shows a greater than 93% reduction in the risk in you becoming hospitalized or having to be placed on a ventilator or dying. So the vaccines and the boosters do work. They help mitigate and minimize the overall severity of the illness that you have, and is our best bet to get over the pandemic, with the hopes that this will eventually become endemic or be part of our normal flu routine and rotation that we see prior to COVID. We still offer open testing at our facility, and if you can contact our number at 845-790-8855 if you're interested in having testing. We still have our drive-up center, and the PCR testing can be performed. One corollary, you still need a physician order to have that test performed. Finally, I wanted to go over our recovery program. This is a program we set up based upon the long COVID syndrome that we're seeing in a large proportion of people that are having or infected with COVID. This is a program that is centered both on the Connecticut side of our health system and also on the New York side of our health system, where the first appointment is via telemedicine, really to assess your overall condition, symptoms, medical history, risk factors, tests, and ongoing treatments. The physician who you would visit during the telemedicine visit will then make recommendations for symptom management and or provide referrals for further testing or other specialty care. This is a syndrome that we are seeing more of. Some of the latest data shows that the people that are at highest risk of having long COVID, where the symptoms just persist, that tend to be people with adult-induced type 2 diabetes, and also people with Epstein-Barr infection in the recent past. So that's just stuff that I've read over the last few months. But this program is a great resource for the community and for people that have had the long COVID syndrome. Next slide, please. Let's talk about our national and rural trends. As you could see, in September, when we announced that we were developing and working on our transformation plan, we really wanted to show the rural trends that are affecting the majority of the United States, particularly here in Sharon. And actually, Sharon mimics the challenges of rural and community hospitals across the country, whereupon we are seeing an aging population. We're seeing an increased demand for primary care, particularly geriatric-focused primary care and outpatient-type services. So with healthcare changing with our demographics, more of our patients are looking on the outpatient realm for healthcare. And we're seeing that across the board, where the number of hospital beds by the federal government has been slowly, before the pandemic, have been restricted because there really hasn't been the need for the massive amount of beds that were necessary for a lot of outpatient-based acute care services. So where we stand out and exemplify how well our experts and our providers and physicians and staff excel is that we are very good at having people come to our facility, be evaluated, and at the facility determine, one, do we have the expertise, the equipment, and the resources available to care for that person? Or two, do we make the assessment that it may be best to be transferred to one of our tertiary hospitals within our health system for further care and management, with the downstream long-term rehab, extended care facilities, labs, and testing be performed again at our facility. And we've been doing this on average since the hospital's purchased, even by HealthQuest, at greater than 300 patients per year. And that number has been very stable. So we're really good at saying what we can do and what we can't do. And with that, we are really working on shifting the type of care that we offer. We're seeing a reduced need for critical care services, reduced need for non-elective surgical procedures, i.e. emergencies. We're becoming more of a outpatient elective type surgical type center, and we're also seeing a reduced need for labor and delivery services. And at the same time, those wraparound services we talked about that we would see for an aging population, such as endocrinology, diabetes management, hypertension management, cardiovascular care, neurosciences for rheumatology, etc. All of those services are the services that we need. And those are the ones, unfortunately, that people have found over the years in rural healthcare are very difficult to recruit to a region because they don't come single anymore. You need to hire them in twos or threes or fours because the lifestyle is so onerous for a lot of these people, being on call 24/7, 365. So that's the change that we're seeing in healthcare today. Next slide, please. So with that as a background, where we are today, we then decided, okay, what do we do in regards to Sharon Hospital with all of these changing trends? So we had a prolonged planning process where we didn't unilaterally just say, hey, let's go ahead and switch things around. We really looked long and hard. We had conversations with our board. We looked within ourselves with our staff leadership. We also took advice from Foundation for Community Health. We had community forums in the past. Particularly, we do that on a biannual basis based upon the terms of agreement with the state of Connecticut and the Office of Health Strategy regarding the purchase of the facility by HealthQuest, and then consequently the merger with Western Connecticut Health System. So we have those, we had community forums, and we still have those, the last being in December. We look at our demographic trends. We do research what other rural health care communities have done, both around us and nationally, and what's working and what are the trends in regards to healthcare. And the interesting thing is, we're looking at the less than 30% of rural hospitals are showing active labor and delivery units at this point. And same thing with a high risk intensive care units are down in the 18 and 19% range for similar reasons: lack of utilization and lack of ability to have the wraparound services necessary to ensure full range care for those individuals. And with that, one final input was our analysis from the Stroudwater Associates. We took the advice from our board members and from the Foundation for Community Health, bringing in an outside rural and community hospital expert to give us advice as to, one, are we thinking in the right way? Two, are we going in the right direction where we need? And three, what services are essentially necessary for our facility to thrive now and be here in the future for the community's needs? So you can see it wasn't just one thing that we used to move forward with our plans itself. We used multiple inputs and multiple areas of interest before we move forward with our plan. And while this was going on, Sharon was losing close to $40 million, and in 2021 it looks like we'll be right around as the books finally closed at around that $21 million loss for 2021. Next slide, please. So with these changes, with the increased need for specialty and ambulatory services, and also we also noted behavioral health is also an area where the data shows that greater than 50% of the population in their lifetime will need and seek out some help for behavioral health, be it through substance abuse, depression, or neurologic issues in the future. So this really is a big issue. So we noted, as I previously described, that the changes in care from critical care services, surgical services, and labor and delivery, that we see a decreased utilization in those areas. But we took the plan and we decided, let's invest, let's enhance in certain areas, and let's adapt in those services that are underutilized and are actually dragging down the community, or dragging down the facility. So with that, in regards to investment, we decided that we would really invest long and hard in our service lines. And what those are services in our area that our system have made the decision that we will grow and make this a focus for our health system, including primary care, cancer care services, heart and vascular services, and neurosciences. Now, we can't, as a hospital, freestanding, recruit these types of people in and expect them to stay in our region. We saw that occur when everyone started aging out in the late 80s through the early 2000s. It's been very difficult to get other people to come into the area, let alone they're single. You would need multiple physicians in all of these areas if you want to be full ranging. But this is where the advantage of being part of a larger health system has really come to fore. And it really helped us during COVID, or I have to admit, wouldn't be here today. With COVID, the severity of how things hit, we would not have been able to care for the patients we had. And with the people leaving healthcare, I don't think we as a hospital would have been able to keep the doors open. We are really looking across the board and investing in those service lines. We've partnered with the Torrington Federally Qualified Health Center, and in October started their mobile van seeing patients at our facility, utilizing our lab and our radiology imaging center. And we are working on a more permanent solution within the facility itself for long-term clinic. To partner with the FQHC with helping with recruitment in the area, gaining our designation for health provider or health physician shortage area, which we are, but we have to actually receive that federal and state designation. So we're really encouraged there. One thing I wanted to dispel, and this is some of this information that's been out in the community since we made our announcement in late September, was that we are not changing in any way, shape, or form our access to emergency department services. We are open 24/7, 365, and we are not actively seeking diversion or permanent diversion for any services at this point. Yes, we made the announcement that we are planning on closing labor and delivery services in June, but we're still open for business now. And yes, we are working on developing our progressive care unit, combining our ICU and our med-surg unit. But again, based upon staffing, particularly when we had injury and COVID-related issues, we've had to occasionally move those patients or recommend that those patients go to other tertiary facilities within our health system because of our inability for that staff. We have never had staff in our ICU leave or forced to leave due to our change as we decide to combine those units. They have left for moving out of the area and or taken traveling positions. And most recently, we had somebody go out with COVID, another person dislocate their shoulder, but it had nothing to do with our changes that we are programming in the near future. So I really want to let everyone know that. And we've had multiple discussions with EMS on that we are still open for business and we are not changing our times or our access to the emergency room. And we're also recommending, finally, as part of our investment plan, growth in behavioral health services in our geriatric program, which is very strong. We want to move that also into the outpatient or ambulatory realm, and then really look long and hard at the full spectrum of adolescent and adult autism, since that is a need throughout the state of Connecticut, and they've even asked if we could look in that area. Areas that we plan on enhancing are to evaluate and optimize our inpatient care. And this is where we have partially utilized less than 50% medical surgical unit. We have 28 beds and our average census is about 8 or 9, sometimes 10 or 11, but we never have 28. And then in our current ICU, the way it's set up, one floor away and down, it has 9 beds and we utilize between 2 and 3. So to staff that, you need a minimum of 2 staff members in the ICU, and you need more staff members in another unit. Based upon Stroudwater looking at our situation, they were surprised that we had not looked at integrating our ICU as a progressive care telemetry unit where we would still be able to handle and care for the patients that we see through our emergency room, that we currently utilize for heart failure, myocardial infarctions, and even some respiratory problems where they could be short-term placed on ventilators and stabilized and then cared for at either our facility or stabilized and transferred to another facility within our system. So they were shocked that we hadn't even utilized that yet. So that's the plan that we're working on right now. And we have filed a letter of determination with the state, and we're awaiting their final determination as to whether do we need a certificate of need for this progressive care type combined unit, which will combine the staffing of those 2 units on 1 unit, and we can flex up and down the unit and actually the room based upon the patient's needs. So the patient could be admitted at a high level of care on the floor with full monitors and a higher level of care per nursing, and then as they improve, they stay in the same room, we can actually start phasing out the need for long-term monitoring and then care for them at a lesser acuity level. That's the magic of using a combined medical surge progressive care unit, and that's what we're working on. And we've been working with our physician team and our hospitalists at our facility, along with our clinical staff, and to develop a good working model and policies all ready to initiate that unit. We're just awaiting state final approval. We are currently using less than 50% of our current facility. This facility was built with greater than 140 beds many years ago, and it's dated in a lot of areas. And so we're looking at a master facility plan to further make better use of our inpatient facility, moving some of the current clinics that we have in our facility, particularly cardiac services and even cardiac rehab, to an area more conducive to the types of patients that we plan on seeing, and also expanding our behavioral health program. So as we work through that, we'll actually give updates once we receive approval from the state to move forward with various issues. We're also looking at optimizing our surgical schedule. Since we will be phasing out labor and delivery once that certificate of need has been addressed. We are currently having active work groups, again, with physicians, clinical staff, and leadership of the system to actually expand our options and expand our level of service for surgical services within the facility. Not back, we are expanding those services. We're only utilizing at most 1 or 2 rooms per day, and we have 4 rooms plus endoscopy, so we have plenty of space. So we're looking at better ways of utilizing the space that we have in regards to our schedule. And I'm encouraged by the teamwork that the physicians and the clinical staff are showing as we're moving forward there. helping the community with digital enhancements, particularly with limited and challenging Wi-Fi connectivity in the region. We are looking at expanding those services. We'd like to thank Congressman Johanna Hayes, who has earmarked $400,000 for our Wi-Fi enhancements, and we started our first kiosk with a workstation that patients who have limited Wi-Fi can come into the facility, see a specialist or a primary care physician utilizing that, having their testing and their imaging there, and going over those results, and pretty much help them rather than having to travel 40 or 50 miles to the physician's office to be seen, or if they have limited Wi-Fi, use our facility for that Wi-Fi access. So we're really looking at expanding this service, and it's currently the pilot is almost completed, and once that's done, we will then start having further specialists from the system actually have access to their schedules for people to visit them. And then telemedicine, I want to say that we're really excited about our just an area that people don't know is our stroke program. We currently are nationally rated in regards to our stroke program, which has only been around a little over a year. And what's the interesting part is we do not have a neurologist on our staff, but utilizing the technology, utilizing and leveraging the skill sets of the physicians throughout our health system, people come through, have their if they come through with acute stroke symptoms, they're evaluated immediately. We follow national protocols, and then based upon that evaluation, can then receive the blood clot breaking medicine immediately at our facility. And if no need for further intervention, they can actually stay at our facility for their entire visit. If, however, they require further intervention, such as a catheterization, etc., then they would be stabilized and transferred to have those performed, as we do not have those capabilities. And just the way, again, utilizing the strengths and the facility that we have available, we've been actually develop a very strong program there. So finally, if you're looking, this is a growth program with investing and enhancing, but only program that we are recommending to be phased out would be labor and delivery based upon the demographics of the region and the underutilization of that unit, which has been less than 0.6 births per day, or 1 or 2 births on average per week. So we're I should say a little bit more than that, because we had 180 births last year. But this has been a difficult area, one for staffing across the board, and then also the ability for long-term growth and cost for that program. So more to come as we move forward. Waiting the state certificate of need, OHS, has given us a docket number, and the entire application is on the public realm for people for review. Next slide, please. So if you go over progress, I gave you a little bit of progress about what's been going on, but if you look at our FQHC partnership, we are currently working on active growth of the program, seeing patients at our facility, utilizing their staff within the mobile van, with the hopes that even down the road, the van could actually go to other communities within our northwest corner, and we would actually have active clinic space within our facility itself. So we're really encouraged by the short time we've been together, just the strength and the speed of how things have been moving for the betterment of the patients in the region. In regards to telemedicine access, as noted, we started our telemedicine kiosk or mobile unit within the facility itself, and patients are actively being seen. And we would hope that this would actually be a more permanent type of aspect of care for multi-specialty areas where cancer care, neurology, neurosciences, and even other heart and vascular specialists that we do not have here in our region could actually see our patients here in our community itself. So we're working on building that program. In regards to primary care recruitment, we've actually brought on 2 primary care providers here in the last few months. I'll show you them in a second. And we're working with our board members who have set up a multidisciplinary committee with other community leaders, physician leaders within our system. They're actually developing a video for recruitment to the region, showing the strengths of the community. This is something that hasn't been done in over 25 years here. So we're working with our community and with our board to work on long-term primary care recruitment and retention, which has been very difficult. Regarding the primary care itself, we're working on an HPSA designation, and we're awaiting a response from the state. So that's encouraging. Regulatory-wise, we've submitted our letter of determination for the PCU med-surg consolidation, and we're just awaiting the state approval there. We also submitted the certificate of need for the application for labor and delivery service phase out. So we're again awaiting that final progress and process. So in regards to continuing community conversations, we are constantly reaching out to our elected officials. I'm on the radio, about every other week now. We have community meetings such as this, and I also participated in a roundtable at Millbrook, New York, just about a week ago. We are meeting with our staff on a regular basis and really encouraging people if they have active questions or concerns about what's been going on or stuff that they've been hearing, please, to contact us, since we are their source of truth, and we should be the source of truth regarding what's ongoing. But what's interesting is, despite these daily stresses with the surge and with the challenges of the national staffing shortage, everybody is still doing their job, and this is still the Sharon family. And I'm proud to say that we have recently been recognized by Becker's Hospital Review as one of the top performing hospitals in Connecticut in regards to patient experience. So despite all of this stuff going on, the people still, and our staff still, are offering top-notch care and not being distracted, which makes us all feel proud that this has been a positive issue for us. Next slide, please. So in regards to the investments in people in care, our primary care physicians include Karen Arell and Tamar Wilms, who are in our Sharon and Millerton primary care offices. They started in November and have been very busy. And they're actually one of them is rotating, helping us with our mobile kiosk for telemedicine within the facility itself. Regarding our MRI, this was purchased through a match challenge support that we received last year. It is the largest bore MRI on the market, and it's for better patient experience, particularly those patients that have issues with claustrophobia. As people know, there's the open MRI, which helps people that are claustrophobic, but the imaging is not as good, whereas this is a closed MRI, but it's wide open closed in regards to you don't feel enclosed or claustrophobic, and therefore it gives us the best of both worlds. And this was recently installed, and now we have the highest functioning MRI within our health system. So I'm encouraged there. We've moved forward with our mobile medical unit partnership with our Torrington Community Health and Wellness Center, and we will continue growing that relationship as we move on and forward in the future. And we did set up our telemed kiosk, and we're looking for grant money for support as we continue to grow that service. Next slide, please. Finally, again, more detail for our mobile medical unit. Here are the hours, Tuesday and Thursday, 9 to noon and 1 to 3, with routine screenings, vaccinations, physicals. I should note this is staffed by the FQHC team, not Nuvance Health. But this is where active partnership comes in, and we really have been working well together. And call their number, not Nuvance Health, in regards to appointments. And here's our number here. I'll make sure that Marina has that number for everyone. And you can actually check this out on our website also. And again, they also utilize radiology and lab testing at the hospital too. So we've made inroads in that regard. So I'm encouraged about how this is, who would have thought a year ago that we would have a partnership on site as we grow forward, helping us, all of us, in our need for developing long-term primary care services within the region. Next slide. So again, it's a lot of information I gave today. Hopefully we were clear on a lot of the aspects. Let us know what you're hearing, and we're here to help you as we take Sharon and go through our next chapter and make this a bright future together in our community. So thank you.
Excellent. Thank you, Dr. Hirko. Before we jump into questions, I'd like to recognize Joanne Waters from Community Health and Wellness. And Joanne, I don't know if you had anything you wanted to add. Sounds like a great partnership.
Thanks, Kevin, and hello, everyone. Yeah, I just want to say, this is about us trying to find innovative ways to really bring primary care services to all of the Northwest corner. It happened that Sharon had the idea of being able to let us use their parking lot, which was great to get us started. And that way we have kind of a consistent location and hours for folks to be able to access. Everyone probably knows at this point, and I think I'm due to present in April about our plans to build a more permanent health center in North Canaan, which hopefully will then help all of the surrounding towns. But certainly, where there's a need. And we've also been reaching out to North Canaan. We've gotten calls from Cornwall and Lakeville and other parts of the Northwest corner to see if potentially our mobile unit, which we affectionately call Betty, is able to come and provide the same services that we are now working with Sharon Hospital to do. And it has been a great partnership during COVID and the peak. We gave a lot of vaccines and testing along with what Sharon Hospital was offering for tests. And it's really just about trying to provide access where right now there is a great need for that.
Excellent.
Thank you.
We do have some questions in the chat. First off, will the ORs be open and available 24/7 for emergency surgeries, or will patients need to be transferred elsewhere?
Yes, as we move forward with our plan, we will be phasing, determining the exact need for the emergency surgery need. Based upon our data so far, and over the last few years, I should say almost 2.5 years, we have not had emergency surgeries at night at Sharon Hospital. So we have had semi-elective procedures and urgent procedures that actually can be done, and people would arrive in the middle of the night and they're actually performed the next morning. Particularly, we're seeing that with appendicitis. The days of the rapid emergent appendectomy just aren't occurring. A lot of physicians and surgeons, and the data show that people have been having those surgeries done the following morning when you have a well-rested team there. Obviously, we will look long-term in the future to determine what our need for emergency care is at night. But there has not been that need. And that's one of those services that we noted that actually dropped off precipitously over the previous 5 years.
Excellent. There is a question regarding training. If there is going to be a combining of the ICU with med-surg beds, how do you ensure that everyone's that broad need for training, across both areas? How do you ensure that training takes place?
Since we're thinking about doing this starting in late September, we started having our nurses on the floor be trained in working with monitors and working with some of the higher level medications, which would fit what a standard medical surge unit would use in any other facility. So they actually have had and are currently ongoing training for reading EKG strips, reading the monitors, and moving forward with that. And again, once we have that date that we're allowed to fully utilize that type of unit, then we'll ensure that we have that stable staff there to move forward there.
Thank you. Next question, what are the long-range plans for New Balance? Is there a possibility of any merger with a larger health system?
As I always tell people that I'm asked that question, I said, if you've thought it, we've thought it also. So we're at that phase where healthcare is very volatile, and there are strange bedfellows throughout. Look at Yale just announcing over the last within the last week, their assumption of care of 3 of the facilities in the state of Connecticut. So there probably are discussions that are even beyond me or above me, but our job is to continue with the resources and the hospitals we have in our current system, and find a way to make them all active cogs for the greater good of the community.
Okay, and this question might be best for Joanne. How many patients have utilized the van since it started coming to Sharon Hospital?
So in total, I want to say since we started, there has probably been maybe about 40, but that includes, of course, we're in the middle of the winter and the focus had been on vaccines and testing. So for the most part, folks were coming in for those services. We've seen maybe 5 or so folks for primary care. But then again, we're trying to do this out of a mobile unit in the middle of the winter. So that also is a factor, but Sharon Hospital has been very gracious to offer us some space so that we can make it work in terms of a wait space inside for folks and a registration space inside as well. We're hoping that with some additional promotion that we plan to do in the very near future in the spring, that those numbers will start to pick up so that folks are aware that we're there to offer primary care access.
Excellent. That is it for the questions in the chat. If anyone else would like to ask a question, go ahead and unmute yourself or post it in the chat. We have a question from Michael Gold. What are the plans for geriatric behavioral health unit?
Sure. About 2 years ago, we actually filed with the state to expand our behavioral health unit from 10 to 16 beds, and we finally received full occupancy about 1.5 years ago. And based upon staffing, we were at full occupancy until COVID hit. We've been running around 70-75%. And a lot of that is actually not due to lack of patients, it's due to the lack of ability to have trained staff. As that expands, we're looking at building an outpatient ambulatory clinic for geriatric medicine, and also possibly expanding the unit further based upon what our facility can offer. So we're looking at 2 realms of expanding the geriatric care there. It all depends on what funding we can receive, and looking at how it best fits in the overall spectrum of care that we currently are offering at Sharon.
This is a great opportunity, I think, in terms of partnership with other facilities. The geriatric behavioral health is such an issue in facilities like mine that aren't equipped. We don't have the proper facility. I would love to see telemedicine access to physicians regarding this, whether it's in our facility or whether it's for folks at home. on home care and struggling. This is a big issue because there's no place for folks with severe issues around geriatric behavioral health to be other than the hospital, and it's difficult to find services. So put that out there.
Oh, definitely no. And that's part of the ambulatory or outpatient realm of utilizing the technology, because there are limited numbers of physicians that actually care for that population in our region. And we're looking at finding ways to expand their reach. So that's one of those areas. So thank you. Thanks for reminding me, actually.
Mike Hebert, you want to unmute and make your comment?
Good morning. Wonderful presentation, Mark and Joanne. Thank you. It's great to see the partnership. And I had just thrown into the chat, just in terms of other with the demographic trend of the increasing geriatric population, are there other gaps or pain points that you're seeing that you could need other partnerships, other relationships with, in terms of social determinants of health and community education and outreach programs for caregivers? Something, I was on a call yesterday, and it was a tremendous conversation with the Tufts Health Foundation about the shortage of resources for caregivers to assist. As you've identified some needs here, e-consult with possibly a thought with teaching health centers. I know that's very difficult to establish in HRSA. The money kind of went away, but are there other opportunities to increase behavioral health services or recruit specialists in those areas? If not, people coming into the region using e-consult to do something like that?
Sure. I mean, in the middle of summer, I'll let Joanne speak on this, but the state attorney general came over and we were part of a roundtable, and he mentioned multiple programs that are out there that they're looking at loosening up some of the funding for us, particularly substance abuse or use, training for people in gap services, as you had mentioned. And one of the areas that as we are really looking at is that adolescent adult autism, which is part of the spectrum even of geriatric health that we see with the chronic depression. So you can see it fits that whole spectrum. We have probably on a weekly basis, one child or one adolescent that is boarded in our emergency room awaiting beds. And sometimes it's 3, 4, 5 days before they can actually get a bed. So that is definitely a shortage area. So hopefully we can get that moved forward. Joanne, I don't know if you have any other.
Yeah, no, echo your sentiments, and thank you, Mike, for the question, because it is a very important part of when we're doing an analysis of really what are the gaps. We know that, obviously primary care in a more rural area is so critical and will become even more so in the next couple of years, and how we all work together. There are some advantages to our designation in terms of trying to recruit the right folks to be able to handle what is needed in a population as you look at that, the needs assessments there. So, we can do some different things that others might not be able to do to recruit in providers and those with special skill sets. And then certainly we can't do this job alone, right? We need our community partners to help us do things that, we can't do completely in our organization. So we are on the Unite Us platform, and hopefully more folks will grow on that in order for us to make appropriate referrals as we identify social determinant needs. And of course, there's always bigger needs that, are more than just a referral process, and it takes a village for us all to come together and figure out how we fill those gaps. So certainly community partnerships are valuable and something that we know, are very much needed in order to meet the needs of a community at large.
Other questions?
I saw a recent question about the ICU again. And I have to reiterate that the ICU, what we're doing is we are relocating the ICU. The current level of care that we're offering in what we call our ICU will be offered in another unit within our hospital as a combined medical surge, progressive care, telemetry unit. So we are not closing or are stopping that service. We are just relocating that service. Now, there are always going to be some patients that come to our facility that require a higher level of care, such as a very high level ICU that we have never cared for at our facility. We stabilize and move out. So our plan, as we had notified the state, is to continue to care for a vast majority, greater than 95 to 97% of the people we are seeing today at our facility, we will continue to see in our new combined unit. So,
well, just urgent care needs, Mark. So many insurance plans discourage people from seeking urgent care need in the ER, and yet in our area, you got to go quite a distance to get to an urgent care facility, 30 minutes or so. Is there any thought of that in the Northwest corner?
Yeah, I mean, urgent care is always that's a touchy subject with that. I know even our health system, we're looking at how do we expand urgent care services without utilizing an inpatient emergency department. So what we're looking at is by expanding primary care services in our area through the face-to-face and the technological means, we would be able to fit what the current insurance plans are recommending for acute services. So it's a long-winded answer, but it is complicated because, as you had so aptly mentioned, in a rural area, the ED is the jack of all trades, and that's been traditionally the jack of all trades. So we're trying to maintain the full ED, but we're also trying to recommend that people be shifted to the primary offices. Our problem is we have a primary care shortage in the region, and so we're trying to balance both. And that's why we do have active discussions with CMS and with the insurers, because it is difficult based on some of the mandates. We're seeing that with endoscopy within our health system because a lot of our endoscopy centers are in the hospital, not in ambulatory centers. And they're saying that the government's not looking kindly at that either. So it's a balancing act.
Other questions or comments? I'd like to save the last few minutes for Joanne to give us an update from the chamber, but one last question, Mark, I am so in tune with everybody else regarding the difficulties in recruiting nurses, CNAs, physicians, all of it. And I don't see this problem being resolved in the coming months or the coming years. This is going to be something we live with for a long, long time. Just any thoughts, anything innovative you were thinking about at New Hampshire?
Yeah, you hit the nail on the head there. We expect this to be a 5 or 6 year issue, particularly for nurses. So we have started looking at the international nurses like any other health system, but we're late to the game there even in tapping that resource. We are developing different care plans and models of care within the hospital, where traditionally if a nurse would care for 3 or 4 patients, maybe they'll care for 6 to 10 patients, but they'll have 2 ancillary helpers, a medical assistants or LPNs or somebody else with them, where we use a team type aspect where the care is compartmentalized, where maybe a pharmacy tech handles the medication reconciliation, maybe a tech comes by and handles the washing and the vitals, and then the nurse will be there for giving the meds and for doing the goal is to have everyone practice at the upper limit or level of their licensure rather than the lowest limit. So we are looking at those models of care and changing those. And that's the way I think it will be evolving over the next 3-4 years.
Yeah, it's so smart. Universal workers, like you said, functioning at the upper level of their training. Just one last thing, we're working with Jocelyn Ayers and others in the area to try to improve and enhance access to housing. And if you're thinking about foreign nurses or other folks coming in, housing and living in the area is always going to be the challenge. Access to not cheap houses, but reasonable rents. And I think that's just something we should all be looking at. You have to have places for people to live, even before you have the jobs. So.
Well, that was the first concern that that we brought up to our board members. It's saying that we can recruit anybody here, but again, there's no housing for them to live. So we have to find a way to get that middle ground and look for some development or other, again, unique ways of thinking in regard to having a consistent area for housing for people to come through, because even with temporary workers coming through, they strongly noticed and they brought to our attention that issue. So that's one of the reasons why the board has been working well with a lot of the community leadership in developing plans to move this forward. So I keep my fingers crossed that we can get some headway there.
Excellent. And Sue, I'd love you to speak just for what you're doing at Advance for the bilingual program.
Excuse me?
Yes.
Sue.
Oh, Sue, yes.
Good morning, everybody. We have had difficulty running CNA classes at Advance because of low enrollment. We might get 1 or 2 students, and we found out that many of the other training facilities are in the same boat. So I've been talking with Aaron Kennedy at Northwestern Connecticut Community College to see that if we could pool our resources so that we could have enough students to be able to offer a class using their wonderful new facility, with us providing staffing to do the training, and working in coordination with a local nursing home or healthcare provider to do the clinical aspect, now that the virus seems to be receding a bit. So we're probably not, we're currently running a class for CNAs at Advance. We have 6 students who are enrolled. So we're probably looking at something for later in the summer or in the fall. And we would be able to offer ESL support services to help students and candidates with language difficulties that they need to overcome in order to be successful in passing the prometric licensing exam.
Excellent. Okay, we are just about out of time. Joanne, the last few minutes are yours if you'd like to give an update.
Yes, thank you so much. And Dr. Hirko, thank you. It was excellent. Very, very informative. And I love the questions and answers too. It was great. We have quite a very an exciting announcement. As you may know from our newsletter, we have moved out of our suite. We've sold that suite, and we are waiting to sign the lease at 59 Field Street. It was across from the courthouse in downtown Torrington. It was formerly the Registered Citizen Office. So we are excited about that and hope that that'll happen very, very quickly. And hopefully we will be in the first week of March. But we do have some exciting events coming up. We know that recruitment of employees is tremendous. So we have a job fair at the Torrington City Hall on March 24th. You'll hear more information on that. And very exciting is our annual meeting is Friday, April 1st. We're awaiting confirmation from Governor Lamont to be one of the keynote speakers, but we also have an affirmative from Dr. Terrence Chang, who is the new president of the Connecticut State Colleges and Universities. So it'll be a very exciting meeting, and we look forward to seeing you at the Litchfield Inn on April 1st. So we're moving forward. We'll stay in touch with you. Kevin, thank you. This was a wonderful meeting. I love the questions and answers, and the presentation from Mark was excellent. I think it answered a lot of questions for people. So this is great.
Okay.
Thank you.
All right, Brooke, are you on? Plans for our next meeting?
Yes, I am on. Our next Northwest Cares meeting is on Wednesday, the 2nd. At this time, we do not have a speaker.
Okay, maybe Joanne, you'd be willing. I know you have a lot of plans, so. Okay, everyone, thank you very much for your attendance. We will make the recording available to anybody who wants it, and have a great day, okay?
Thank you.
Thank you.
Thank you.
Thank you. Thank you, Dr. Hirko.
Oh, thank you.
Thank you.